Like I keep discussing, we're not going to specifically talk too much about colorectal cancer, except for the fact that it is generally caught with screenings. But this is an interesting diagram because it shows where colorectal cancer is most frequently found by percentages. So the highest percent is going to be in the rectum, followed by the sigmoid colon, 22% in the ascending colon and cecum, and then only 11% in the transverse. Colorectal cancer obviously refers to cancer in the colon and the rectum, which make up the large intestine together. Most are adenocarcinomas, which are tumors that arise from the glandular epithelial tissue of the colon. We have some risk factors and etiology on this page as well. If possible, generally we'll see surgery for colorectal cancer. We'll generally see a surgical removal. And if possible during the surgery, the tumor is going to be removed and the two ends of the colon will be anastomosed or reattached to one another. And that's called a colon resection. So that's our best case scenario. And that usually doesn't have, I mean, it's going to cause some changes, but it's not going to be as significant as if we would need to have an ostomy. So colostomies are, I'm sure most of you have seen them. They are essentially when we bring the colon outside of the body. So this graphic here shows where the locations of colostomies can be. This is found in the 8th edition of IGGI on page 1153. So our role here is going to be reinforcing the surgeon's explanation of the colostomy, of the actual surgery, but also of what's going to happen afterwards. Answering questions related to changes that are going to occur is going to be a huge part of surgery prep as well as recovery. Often a certified wound ostomy and continence nurse is going to be consulted for education pre-surgically. The table on IGGI 8th edition on page 1152, it's table 56-2, pre-operative assessment by the CWOCN prior to surgery. That's a pretty good assessment of what's going to happen before surgery. So here are some of the types of stomas, fecal stomas that we might see. Loop stomas are often temporary. It's where the part of the colon is brought out through the skin and the anterior wall is opened up and a rod might be used to keep it in place. So this is a graphic of, a diagram and a graphic of a loop stoma. So this is, you can see this one is in the transverse colon. These are less likely to be permanent. So usually this is going to be a temporary stoma. It's, when we have these loop stomas, we have to be really cautious of keeping that rod in place because that is what's helping keep the stoma in place. So especially with bag changes, we have to be really careful. End stomas are, they most often occur in the descending or sigmoid colon and are usually permanent. So this is, we're going to see some end stomas here. That C diagram shows an end stoma from the sigmoid colon. A double barrel stoma, that's the bottommost stoma on this image. That's a double barrel colostomy. That's going to be the least common. I've never seen one of these. This is where they actually create two different stomas, where that top stoma or that proximal stoma is going to be the functioning stoma where we see the stool, the feces is what's going to come out of there. And then the distal stoma is, it could create some mucus, so there might be some mucus coming out of there. Usually after surgery, stomas are generally functional within 2 to 3 days post-operatively. This graphic here shows what we can expect to see depending on where a stoma is. And as you can see, as we move along the GI tract, it just makes sense that the stool becomes more solid as we move along. So in the very beginning, by the ileocecal valve and moving up to the ascending colon, we're going to have fluid or semi-fluid stool. And it becomes more and more solid as we get closer to the rectum. Because obviously, just like as we get closer to the rectum, whatever comes out of the ostomy will be just like what would be defecated from a normal bowel. Whereas if we take the stool from the ascending colon, there has been less time for the colon to remove water. So it's going to be very watery and loose stool. Here is a nice healthy stoma. So when we care for colostomies, we of course are going to need to assess the appearance of the stoma and make sure it's nice and healthy, like that last picture. Complications are going to be pus, necrosis, especially complications around the site of the stoma. We have to be careful that it's kept clean and dry so we don't see the skin surrounding the stoma break down. We need to measure the stoma because we want to make sure that it doesn't herniate itself and start essentially plunging out of the hole. We could, at that point, if we have an increased intra-abdominal pressure, the stoma could start coming out of the hole of the actual stoma. Using appropriate appliances is going to be important, and that we're going to usually see a woundostomy nurse to help with. Dietary measures to control gas and odor. They're in our Iggy book, 8th edition. There are a bunch of really good postoperative physiological and psychosocial implications that I'd like you to look at in Iggy 8th edition, pages 1155 to 1156. And that does include some dietary education information.